Okay, Bismillah ar-Rahman ar-Rahim. Thank you very much. Let me just start with thanking Prof. Ahmed, Dr. Hajar, all the other members of the steering committee for organizing such amazing event, and also to thank the organizers for nice organization. Thank you very much. Actually, I'd like also to thank Prof. Awan. You made my life easy, and you did not leave anything for me to speak about. Okay, so let us start, please. Nothing to disclose. Yeah. I think Dr. Awan speak about that. FH is an autosomal dominant hereditary disease with the three major features of hyper LDL cholesterolemia, premature coronary artery disease, and tendon skin xanthomas. Usually, the familial hypercholesterolemia underdiagnosed and undertreated, especially in children. Because of that, we are trying to speak about the diagnosis of hyperlipidemia in children. Dyslipidemia, obesity, and other risk factors in childhood predict adult cardiovascular disease affection. Importantly, normalization of childhood risk factors can decrease or even eliminate adult risks. So it's really important to diagnose hyperlipidemia in early ages so you can prevent the future cardiovascular diseases. Early diagnosis and intervention improve the prognosis. I will not speak about all these things. The Professor Awan already speak about it. So the latent or early symptomatic stage, it's really should be recognized in children because children and young adults with familiar hypercholesterolemia are rarely symptomatic, while cardiovascular typically manifests in adulthood. The process begins in childhood. Identifying children is critical to reducing the burden of disease in adulthood. So this is why we would like to screen patients for hyperlipidemia. We would not wait until the disease occur. We want to screen them. So the suitable test for screening, majority of FH children and young adults have no physical symptoms, as we said. So blood testing, cholesterol, quick, easy, not invasive, and it's affordable everywhere, while the genetic testing is still economic problem or economic challenge in that issue. So what is the suitable test examination? Summary of the US task force. From 20 to 35, it's recommended if you have a case. Then if there is increased risk of cardiovascular disease, 35 and other strongly recommended even without any cardiovascular disease. Women 20 to 34 to 35 recommended if at increased risk of cardiovascular disease, and 45 and above and older strongly recommended if also there is a history of cardiovascular disease. As we said, the suitable test is actually it was debated whether we test the total cholesterol or test the LDL only or triglyceride, whatever. So all are measures to test to screen for hyperlipidemia. Optimal interval for screening is uncertain. Reasonable options including 5 years or sooner if clinically indicated. So if you test the patient, not the index, the other cases, and still it's negative, you may wait for another 5 years to test them again. This is also, we're talking about screening. I will just summarize it because I have been ordered that to finish as quick as possible, so I will try to summarize as much as I can. The European Atherosclerosis Society said children suspected of familial hypercholesterolemia should be screened from the age of 5 years. And as we'll just mention that also some they say at 2 years you have to start screening. The most important thing is cascade screening. So whenever you have and in this case, it's better to cascadely screen all the family. Universal screening, it's expensive actually. If you want to do and the population, all the population screened for hyperlipidemia by either total cholesterol, it's really costly, but it's one of the options. The literature suggests that the optimal age range from between 1 and 9 years, but we say, as we said, the European Society, they said from 5 years and above. Cascade screening, the most important thing that you can detect one case in 5 children. So it's good to do that cascade screening, and it's really important to emphasize that, to do this cascade screening. We'll go to diagnosis. We can go back. Yeah. Clinical I mean, the step of the diagnosis is first clinically, so that means history, physical examination, then laboratory testing, and finally we'll end with the genetic testing. What I'll talk about is the clinical and laboratory. The genetic testing, maybe Dr. Naji will speak about that at the end. The diagnostic criteria, as we said, is 3 things: that presence of the symptoms, LDL high, and history of coronary artery disease. Family history, premature coronary heart disease, or even of hyperlipidemia. Age less than 55 in men and less than 65 in women. High-low density lipoprotein, cholesterol, LDL-C, while of treatment or 20 years and above, more than 190, or less than 20 years in children, less than 160 or above. In treated patients, whether he's child or adult, more than 124. So we say that familial hypercholesteremia, it's family history and high cholesterol, if you can, as a diagnosis in general. Physical examination, you find xanthomas, corneal arcus, xanthelasmas, and Professor, I want to just show you something, and I'll show you also the xanthomas, the corneal arcus, xanthelasmas, and xanthomas as a presentation, and corneal arcus as a presentation. In children, you can see it in children with hypercholesteremia. And I think Professor also talk about secondary hyperlipidemia, and in children also we have to look secondary hyperlipidemia, because it has the same thing, similar symptoms and signs, especially if it's severe hyperlipidemia. Severe cases can reach to high levels of LDL cholesterol. Cardiovascular can also occur I mean, the history of cardiovascular disease, you can also find it in secondary hypercholesteremia. And the causes, maybe he just mentioned diet, disorders of metabolism like diabetes and hypothyroidism, and drugs like cortisol and testosterone. So because of that, there is some confusion between secondary hypercholesteremia and primary hypercholesteremia. It's important to have a criteria. So in this criteria, you will diagnose your patients. And we will see later with Dr. Hajar, with our registry, how many patients we discovered that they don't have familial hypercholesteremia because we applied the criteria. So the criteria, the US MedPed, they are depending on some criteria, some changes to diagnose. Then we have the Simon Broom criteria, the National Association for also consideration of screening diagnosis of hypercholesteremia. They have some ideas or criteria. And finally, the Dutch, and that's actually we are depending on in our guidelines and in our protocol. We are we are applying the Dutch criteria for diagnosis. As you see here, first of all, the family history, whether first degree with premature coronary heart disease, or first degree with LDL cholesterol high more than 5th percentile, 95th percentile, and first degree relatives, and so on. We can diagnose the patient. So if we have more than 8 points, this is definite of familial hypercholesteremia. If we have from 6 to 8 points, that means it's probable. If it is from 3 to 5, that means possible. If it's less than 3 points, that means this is not familial hypercholesteremia, and we have to stop the medication if the patient on medication. And actually, through our registries, we found a lot of patients, even at the diagnosis, they don't fulfill the criteria and they don't have even 3 points to diagnose them. But they started on big guns like Repatha and other medications. And this is just a comparison between the 4 criteria. As you see here, the MedPed only taking family history of hypercholesterolemia, if it is positive, and if the LDL-C is elevated. So then they will diagnose familial hypercholesterolemia and they will start the treatment. As you see here, there is a lot of information is not there. For the let's just leave the Dutch. The Simon Prom, they are concentrating on the family history, but the patient himself, they are not, like patient premature CAD or patient with premature vascular disease, they are not considering in the diagnosis. And elevated LDL-C and also genetic mutation. So the xanthomas is there with the Simon, but the ARCAS is not one of the criteria. In the National Association, they also depending on family history and the elevated LCL and so on. The last one, the American Heart Association, they are depending on family history and elevated LDL-C and genetic mutation. Unfortunately, genetic mutation is not available and affordable everywhere, so we cannot depend on it as a diagnosis. We know that if we have genetic testing and we have genetic diagnosis, this is 8 by itself. So we can diagnose familial hypercholesterolemia and we don't need to go through the other things. Just in summary, heterozygous familial hypercholesterolemia, LDL-C more than or 160 milligram, that means 4.1 millimole for children, and more than 190 or 4.9 for adults, with one first-degree relative similarly affected or with premature coronary heart disease or positive genetic testing. In heterozygous, the LDL-C more than 400 or more, one or both parents having clinically diagnosed with familial hypercholesterolemia. This is for homozygous. For heterozygous, the presence of first-degree relative with confirmed familial hypercholesterolemia on LDL-C is not a criterion in family history of familial hypercholesterolemia. With genetic testing, as you see, the presence of one abnormal LDL-C raising gene defect and LCL less than 160 milligram per deciliter. Occasionally, heterozygous may have LDL-C more than 400 milligram per deciliter and presence of both abnormal LDL-C raising gene defect and LDL-C lowering gene. So just a summary of how can we differentiate between familial hypercholesterolemia, homozygous and heterozygous. And in general, we speak about how to diagnose the familial hypercholesterolemia in children. I know it's difficult to diagnose in children, but we have to suspect, we have to anticipate if there is family history of hypercholesterolemia. Thank you very much.